Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, TNFOG with Uttarakhand Societies. So let us start the webinar with Saraswati Vandana. It's my privilege to introduce the MOC of today's webinar, Dr. Madhumita Arun Karthik ma'am. Ma'am is the National Coordinator of Midlife Management Committee, FOXY, South Zone and TN State Coordinator, FOXY Presidential Activities 2026, FOXY Youth Cell Member. I welcome you, ma'am, and I hand over the session to you.
Thank you so much, Sahiti. So it is my privilege to welcome one and all for this very interesting and informative webinar of TNFOG along with the Uttarakhand Society. And I'm honored to introduce the convener of this program, Professor Dr. Sampath Kumari ma'am. Sahiti ma'am, slide please. Ma'am is a past vice president of FOXY. She is also the past chairperson of FOXY.
Madhumita, leave it.
Yes.
We will proceed. It was already 5-8. Madhumita, ask others to rename it.
Yes, ma'am.
Because doctor, we may not be.
Faculty, please rename.
Yes, we will proceed. Okay. Good evening to all. I welcome you all for this webinar series, which is TNFOG with other states. This week we have TNFOG with Uttarakhand Societies. I welcome the President and Secretaries of Dehradun Society, Haldwan Society, Haridwar Society, Rudrapur Society, Roorkee and Kashipur Society. Followed by this, we have the two sessions. One session being the talk by Dr. Shantirani E-Motive Bundle. Since Shantirani is not available, this E-Motive Bundle will be dealt by me. And the second session being the panel discussions on hypertensive disorder in pregnancy. Moderator being the Priya Kannappan and expert being Rekha Rajesh, and with interactive panelist. Now we will go with our chief guest, Dr. Fesi Louis and Dr. Palaniyappan is the chief guest for our webinar. First, Dr. Fesi Louis. Dr. Fesi Louis is the professor and HOD, Department of Reproductive Medicine, Amrita Institute, and FOXY Vice President 2022, ESAR National Executive Member, ICOG Governing Council Member 2021-23, Vice Chairperson of Kerala Chapter IAG and Secretary of Kerala Chapter of ESAR, Reproductive Committee Chairperson of KOFOG. And,
okay, madam. It's okay, madam.
Yes, Fesi. Stage is yours. A few words.
Okay. Good evening to all. First of all, let me congratulate the TNFOG for having this wonderful initiative. I think TNFOG is Tamil Nadu Federation of Obstetrics and Gynecology. Madam Sampath Kumari Madam is the founder secretary and the present secretary. And we have in Kerala also, we have Kerala Federation, for which I was the secretary from 2012 to 18. Now I am the president. So always I feel that like this initiative will bring all of our gynecologists, not only the gynecology, if you tell Foxians, or not only the Foxians, all Indians from different part of the country together, because in addition to our practice obstetrics and gynecology, what we have to do is that we have to have a good bonding. That is the one big thing what we usually get by this by means of Foxy. I think that is being really mooted by like this joint webinars, especially initiated by the TNFOG by Sambat Kumari madam, and also the chief guest along with me is Palaniappan. He is also the past vice president of Foxy. So I'm happy that today in this the Uttarakhand societies like Dehradun, Haldwani, Haridwar, Kashipur, and Roorkee and Rudrapur has agreed to be part of this. And if you look, today's topic is really nowadays the obstetric topics are very less. Today's one important topic is the e-motive that is regarding the PPH bundle. E means early detection, motive means uterine massage, oxytocin drugs, tranexamic acid, intravenous fluid, and examination or emptying. So that all these things which along that the hypertensive disorders, the second panel discussion, will be updating and polishing our knowledge, not only for the postgraduate, but the practicing doctors. It will really help in their practice. And I'm thanks for the TNFOG for especially Sambat Kumari madam for inviting me, and Dr. Madhumita who is coordinating this. And also wishing all the best for Sambat Kumari madams for her election, Foxy election, which usually the importance of these meetings that people has to vote. Most of the time, gynecologists are not bothered. Whenever some CME occurs, they will just go and listen. After that, they are not concerned. So the we must spread the message that we have a commitment, just like our voting rights for association. Also, we must be doing our voting rights, and we must mobilize all our fellow Foxians of your respective society to vote and make the association more important in our practice, so that socially and academically we will grow and become. This is one of the biggest professional body in the world with and in one specialty if you take. And also we urge all of you to take the social security scheme of the Foxy, because right now, even when we have more than 40,000 members, social security scheme members is hardly 5,000. So that really will help us to grow our society and all the way academically, socially, and concerned to our fellow gynecologists. And wishing all the best for this webinar. Thank you for inviting me. Thank you. Wishing all the best for Samat Kumari madam. Thank you.
Thank you, Dr. Fesi, for the nice words and for accepting to be the chief guest in this webinar. Next, our own Dr. Palaniappan. Dr. Palaniappan is the professor and unit head in Ramachandra Medical College, won the Indumati Javari Award in 1994 and Young Scientist for 1996, A.L. Mudaliar Traveling Fellowship 1998, and
Thank you.
Dr. Palaniappan is one of the member of the founder of TNFOG. We 7 people were roaming around in and during the COVID period to establish this federation. Thanks to Dr. Palaniappan. When he was Oxy president only, we celebrated the inauguration of TNFOG. Welcome, Dr. Palaniappan.
Good evening, ladies and gentlemen, respected Sampath Kumari madam and Dr. Fesi, and of course the members of the Uttarakhand Society constituting the Haldwani, Haridwar, Kashipur, Roorkee, and Rudrapur societies, presidents and secretaries, and of course members who joined. The topic has been very well chosen, chiseled and paneled, and good that we have the e-motive bundle and the panel discussion on hypertensive disorders of pregnancy. What we should probably looking at in the e-motive bundle is the tranexamic acid. The rest of the things are quite there. I'm sure there will be some discussion on tranexamic acid, which probably is not very well used in the Indian scenario due to the anesthetist not being very very much okay with the tranexamic acid. I'm sure there will be some discussion on that as well at the end of it. And so we need to reiterate that emotive bundle is coming after the women trial, blah, blah, blah. Tranexamic acid has been doing very well. So we need to think in terms of how to reinstitute the usage of tranexamic acid. And of course, the hypertensive disorders of pregnancy. Sure, they will discuss the recent advances and the management. The whole session very well organized by Dr. Sampath Kumari and ably helped by Dr. Madhumita. Very good. We're very, very happy to be a part of this meeting. And I only hope that the members of the five societies of Uttarakhand have joined in good numbers. The very purpose of me joining today is to request you all to vote for our own Dr. Sampath Kumari for the forthcoming elections in the Foxy presidency candidature. What is very important about Sampath Kumari, if we talk about her CV, it will go to pages, and I'm sure you all know that everybody's CVs will go on to pages. But what is very, very striking about Dr. Sampath Kumari is she's a very simple person, very humble person whom we can just approach and talk to her like anybody else. There is no aura around her in the sense that she doesn't create a big head and she doesn't say that, oh, I am contesting for Foxy president. If she becomes Foxy president also, she will be the same. To quote, I don't know, in Tamil Nadu, we have got a change of political leadership, and the new CM, Mr. C. Joseph Vijay, meets everybody in this assembly, and he goes on the road, talks to the public. Sampath Kumari madam is also like that. And so you can just go and talk to her at any point of time, make a phone call, she'll call you back and she'll be able to help you. And so, ladies and gentlemen, those of you who have joined here, I think it's high time we had a president from South India and especially from Tamil Nadu. And so I wish Dr. Sampath Kumari is being elected wholeheartedly. And I urge, request you all to vote during the August 1st to 10th and vote for Dr. Sampath Kumari. And that's my only plea. And I wish the CME today a very great success and all the best, Dr. Sampath Kumari.
Thank you, Dr. Palaniappan. Thank you for the nice and wonderful words. By God's grace, we should win. We will thank you again, Dr. Fisi and Dr. Palaniappan, for accepting to be the chief guest. Okay, thank you. Madhumita, வேற யாரும் இருக்காங்களா? Otherwise, we will go with the scientific session.
Okay, ma'am. They have joined, ma'am, but it's all faculty. It is named.
They didn't rename it.
Rename.
Okay, well.
Yes, ma'am. So, so we are moving on to the scientific session. We have a very interesting talk on E-Moto bundle by Sampath Kumari ma'am with the chairpersons Dr. Vibha Mehrotia.
Whether she has joined, any
Dr.
other
Vibha?
president and secretary has joined from Uttarakhand Societies, we want to honor, felicitate the president and secretaries because we are not able to identify you because everything is written as a doctor's doctor faculty.
Dr. Surabhi Singh has joined, ma'am, Rudrapur secretary.
Dr. Surabhi, are you there?
Yes, ma'am. Hi.
Yes, Dr. Surabhi. Few words about the webinar. Yes, Dr. Surabhi. Dr. Surabhi is the secretary of Rudrapur Society. Welcome, Dr. Surabhi.
Thank you, ma'am.
Yes, sir. Dr. Pavan, Dr. Preeti, Dr. Abha, Dr. Vibha, Dr. Meenusud, Dr. Rita, Dr. Sangeeta, Dr. Madhu, Dr. Kunjan, Dr. Seema, Dr. Manpreet Kaur.
Manpreet, no, ma'am, someone else is here.
Yes, Dr. Surabhi is the pioneer in management of high-risk pregnancies and infertility, and the first to start the basic infertility management and ART, recipient of ISAR Appreciation Award, at present holding the position of secretary in Rudrapur. Yes, Surabhi, few words about the webinar, and then we'll go with the scientific session.
Surabhi, ma'am?
Doctors, faculty
kindly unmute, ma'am.
You're muted, ma'am.
You can unmute and talk. Who is the other doctor? Somebody is there. Dr. Rita. Yes.
Dr. Rita is there. Dr. Rita Dhawan is there.
Dr. Rita is the president of Dehradun Society. Welcome, Dr. Rita. Dr. Rita, few words. Yes, madam, welcome. Do you have the CV of Dr. Rita? Dr. Rita Dhawan is the president of Dehradun Obedience Society. And Dr. Rita, few words about the webinar. She is unmuted.
Rita ma'am, you're muted ma'am. I'm sorry.
Surabhi or Rita,
Sura-
both of you can talk. Otherwise, we'll go with the scientific session.
Surabhi ma'am had unmuted and again it's muted, I think.
Dr. Rita, do you want to tell anything?
A few words from you, ma'am.
Hi, ma'am. Good evening.
Good evening.
Wish you all the very best for your elections for the presidential poll. And thanks a lot for bringing all the presidents from Uttarakhand together.
Thank you. Thank you. Thank you for joining us. Surabhi?
Yeah, ma'am. Thank you so much and all the best
Thank
for
you.
your elections. And though now I am not in a very good mood,
Yes,
Mummy
yes.
is not too
Surabhi,
well. She's in ICU. That's why
yes,
a little
Surabhi's
late
mother
back.
is not well. We'll pray to God for her faster recovery. Oh, thank you,
Thank you,
Surabhi,
ma'am.
for
Thank you
joining
so
us. Thank you.
Thank
Thank
you.
you. So we'll go with the scientific session. Since Dr. Shanti Rani is there, the emotive bundle will be taken
Yes,
by
ma'am.
me. Dr. Anita has joined. Dr.
No,
Vibha,
ma'am, it's not a join. No, ma'am.
no problem.
We'll go with the ma'am
We
slide.
will go with the presentation.
Yes, ma'am.
Okay. Yes. Can you see, Madhumita?
Yes, ma'am. Yes, ma'am. Yes, ma'am. Slide share mattum.
Yes. Yes, we will go with that. Good evening to all, and I welcome you all for this webinar, which is conducted on every Tuesday. Normally, it is on 8 o'clock. Since Uttarakhand people were available only from even 5 o'clock, we changed this week to 5 o'clock. My topic is on e-motive bundle. This topic was supposed to be shared by Dr. Shanti Rani. Since she has some emergency, I thought I will finish this. See, all of us know about the PPH. See, it is before going to the topic, I'm contesting for Foxy President. All of you, please vote for me. From down south, after long years, we are contesting. And with 34 years of the teaching experience, please support me. See, the PPH, everyone in the hospital would have seen at least a single case of the PPH. But we do not know which patient is going for PPH. So for all patients, we should be prepared that if the patient goes for the PPH, how it has to be managed. The postpartum hemorrhage is defined as the blood loss after 500 ml after the birth and regardless of the delivery. And the PPHs now the definition is also almost has changed. PPH is about the maternal death due to PPH is 35% of all the maternal deaths occurring worldwide. The incidence of PPH is 2 to 4% and 6% after LSES. But again, the incidence of PPH has been increased. So what are all the amounts we can wait is 2 hours, 12 hours. This is one. The cases within 10 minutes, patient can go for the collapse. These are all the causes for which the patient can go for the collapse. But this PPH collapse we have to adjust. We have to see what is the amount of the blood loss. Rather than measuring and taking the gas by the visual examination is the best examination to assess the PPH. The reasons for high mortality is failure to recognize the excessive blood loss. Because when the blood loss is more than 1 liter, only the symptoms, that is the tachycardia and hypotension will be present. So we should not wait till the blood loss goes to 1 liter. So when the patient is, if it is more than 500 itself, it should be very aggressive and try to give the management. And failure to provide the timely management. See, if at all, if you want to go for the surgical management means all the medical management and the mechanical management should have been tried within 30 minutes. You cannot take your own time. The medical management simultaneously always call for help. This e-motive is managing all the possible methods simultaneously. We will be discussing in later. So that's the reason that we should not delay. If at all, if you want to go for the surgical management, it has to be decided as early as possible. And failure to provide early and adequate fluid replacement and failure to refer. If you don't have the facility and if you feel that it is very difficult to manage, means refer the case at the earliest to the higher institute where facilities are available. So the challenges in the management is challenges. One is the estimation of the blood loss. how to assess the blood loss. Sometimes you can have the plastic bag-like thing, or we can assess with the cotton and the gas piece how much it has been wet. And finally, the visual inspection is the best assessment. And the challenge 2 is the delayed and inconsistent use of interventions for the management of postpartum hemorrhage. We are confused. We ourselves is confused whether to go with the medical management or to go with the mechanical management, or suddenly take for the surgical management. And the treatments that we will be discussing, the emotive, as Dr. Fesi and Dr. Paraniappan was telling, the tranexamic acid, most of us are still not using, but it has to be used. However, postpartum hemorrhage is a time-critical condition, and delays in the use of life-saving intervention can result in loss of life. That is the golden period. That is the 4th stage of labor. Has to be monitored. If it have missed that 4th stage, and then we will be in a problem. The priority is what happens if the PPHS means first stop the bleeding. And if the bleeding is not stopped, if it is going to be continuous, means that will be the coagulation problem. And again, because of this coagulation, patient can go for the DIC and organ damage, which is under the perfusions. So these are all the priorities which has to be managed. So after the delivery, the primary PPH, which occurs within 24 hours, and the secondary, if it occurs after that, 24 hours. So always the first stage, second stage, third stage, once the placenta is expelled, the 4th stage, 15 to 30 minutes should be monitored for all the patients, whether it is a normal delivery or whether it is the LSES. And we have to see whether the uterus, once the baby is delivered and the placenta is expelled, the uterus should be like a cricket ball consistency. Suppose if it is like a tennis ball consistency, at any time it can go for the PPH. So always see massage, the Amstel, we are following for all the patients, active management of 3rd stage of labor. That is 20 units of syntocin immediately after delivery of the baby, and controlled contraction and massage. So the massage, if the attenders are also not available, if it is a vaginal delivery, the patient herself can do the massage. So the first 24 hours is the critical period. So the what is the negative implementation is the prevention. Is there any prevention? Because we can prevent the complications. That is, our goal is to assess the early quick management. Whatever, every delivery, we are having a delivery kit and the PPH kit and the eclampsia kit. It should be present in all antenatal ward, in the labor ward, and in the theater, and always when you are shifting in the casualty. Because you cannot search for this. This PPH kit should contain all the needed things. What are all the medical management of the drugs is needed. So the prevent PPH from becoming a major decompensated. So though we cannot prevent the PPH, but identify it is earlier and prevent the complications. So the E-motive trial. What is this E-motive trial? It is the intervention resulted in 60% of the lower risk of the primary outcome. So this E-motive trial, as we have mentioned, examinations, we will see what is E-M-O-T-I-V-E. This all should be done simultaneously. We will see. This is the E-motive. That is early detections and the trigger criteria E. And M is the massage of the uterus. As I told, if it is going to contract and relax like a tennis ball, give continuous massage. Massage itself will reduce the PPH, because once the uterus is contracted, automatically the bleeding will get reduced. Then the O is the oxytocin drug, which I told the 10 units of syntocin has to be given immediately after delivery of the baby. Suppose if the bleeding is continuing, means we can add the 20 units in the drip and maintain it, the oxytocin drip, and it continue the drip and for maintain the contractions. T is the tranexamic acid, which is 1 gram of IV injections of the tranexamic acid should be given. That is, 1 gram should be given after the delivery. The IV fluids. IV fluids is always, when there is a PPH, call for help. One should give the IV line, the other should start the drugs. And when you give the IV line itself, draw the blood sample and say it for the coagulation profile. And then the examination and the escalation. This is the E-motive bundle. So the risk assessment, this is the tools which we can tell that there is no risk factors that this can go for a PPH and this cannot go for a PPH. Suppose if there is a previous PPH, we will be very careful, and this time also it can go for a PPH. The low risk factors is no previous uterine incision, singleton pregnancy, no medical disorders, without any complication. That can be considered as low risk, but this can also go. The medium risk is the inductions of the labor. Always nowadays the misoprostol. Misoprostol is a good drug, but if you not going to monitor, it is the burst drug which can also lead to the rupture of the uterus. The multiple gestations, previous cesarean birth, and the large uterine fibroids, previous history of PPH, chorea, amniotic, sudden fetal demise, polyhydramnios. These are all the medium risk and the high risk. The high risk being the previous LSES. Nowadays, the LSES is an most of the time, the incidence is increasing to 50 to 60%. There can be a placenta previa, placenta PAS syndrome, Acrita syndrome, and a known case of the coagulopathy, and previously PPH was present, and a hematocrit less than 30 and platelets less than 1 lakh. So when will you suspect the features of the PPH? Always the PPH is 4 T's. What are all the 4 T's? Tone, tissue, trauma, thrombin. So the tone is the atonicity, that is the contraction, which I told you, it should be like a cricket ball. Traumatic, it can be in the cervix, or it can be in the vagina, or it can be in the uterus, or can be in the vulva also. So the traumatic has to be verified. When the uterus is contracted, still bleeding is present, means put the patient in the lithotomy position and verify whether the episiotomy wound has extended or the apex of the episiotomy wound is not sutured. And the cervix, visualize in the clockwise position and see whether the cervix is intact with the 3 quadrant. Take 2 sponge holding forceps, put one 12 and 3 o'clock position, and then remove the 12 and put it in the 6 o'clock position. So all the quadrant can be verified. Then remove the 3 and put in the 9 o'clock position. That is, walk around the cervix and see whether all the cervix is intact. If there is a tear in the cervix, don't try to suture it in the labor ward. It has to be shifted to the theatre. Put the packing, and under anesthesia only it has to be sutured, because the cervical tear can also go for the posterior part of the uterus, and it can be lead to the colporexis. And then the retained placenta. Once the placenta is delivered, always controlled cord section. Receive the placenta in the right hand, left hand should be kept over the suprapubic region, and receive the placenta with both the hands and twist such that all the membrane comes. Once the placenta is received, put it with catch the card and see whether the fetal membrane is complete. Then reverse the placenta and see whether all the cotyledons on the maternal surface is also present. If some of the bit is present, we can leave it, because if there is no bleeding with the mesoprostral itself, it will come. But fully entire placenta is not separated, means again, don't try to remove the placenta in the labor ward. Again, shift the patient to the theatre, and under anesthesia, you remove the placenta. It has to be like turning the books. The full placenta has to be caught in our hand in the palm, and it has to be removed. Sometimes the inversion can happen, and finally I told is the thrombin. Always for the antenatal visits, we see the bleeding time and the clotting time, and we will elicit the history whether she is having any bleeding disorders from the birth or in the younger ages. That from that we can see the thrombin. So tone, tissue, trauma, and thrombin is the causes for the PPH. And the quantification measurement is, as I told, it can be a gravimetric, it can be a calibrated plastic sheet. That is, the blue color sheet will be there, in which the calibrations will be present. And use of nowadays, we all talk about the AI in everything, use of the artificial intelligence. And finally, which is working out is the subjective, that is the visual examinations. So the gravimetric method is an indirect measurement of the blood loss. Blood loss can be estimated by weighing the surgical material contaminated with the blood and subtracting the dry weights. But these are all not practically possible. So visual examination only can be assessed. So the calibrated collector bag method, that has to be given before once the baby is delivered. Sometimes what happens, though, the amniotic fluid will also be collected in the calibrated bag method, and it may show us the excess amount of the blood. So it should be very careful. So the bottom of the plastic foil, there is a calibrated collector bag with a scale on which the current blood loss can be read. This is the way. In this way, some left lateral position we have to do. Otherwise, the fluid will also, amniotic fluid will also get collected. So this is 500, 600. Suppose if the 1000 ml of blood is present, means immediately we have to take the action. It should not be more than the 500. These are all the simple calibrated drapes. Now it is available from the Atuna project, I think, even in the FOXY. So this is the use of the artificial intelligence, that is nowadays with this, the calorimetric technique analysis, photographic and geometric information from relevant areas. This GA artificial intelligence can also help by the glass surgical inclinations. So the main is the visual inspection. Visual inspection, we can assess whether the blood loss is normal or whether the blood loss is excess. These are all the simple methods. The gas around 25 ml, this is the 50 ml fully soaked, and the 75 ml bigger causes, and fully soaked bigger causes 100 ml. These are all for calculation. If the fist blood clots in the fist means it is around the 50 gram clots. If it is in the kidney tray means it is around the 500. These are all the simple assessment which can be assessed. This is a quantifications, but this may not be exact. But suppose if the patient has delivered and blood has spilled throughout the bed means it can be of 500 ml, more than 1500 ml, 2 liters. Like that, this can be kept in the labor ward, but it are not actual. So again, we come to this e-motive bundle, which early detections and trigger criteria we have discussed. Always identify the case and the early detection. That is the case by the clinical examination is present. Then the M. M is the massage of the uterus. As I told, that is over the umbilicus region. The uterus will be like once it is delivered, it will, if the thin patient means, it will be like a ball. We can see it outside itself and give the massage. If you give the massage, the contractions will be present. This is the way we are going to give massage for the patient. If the patient has delivered the placenta only, now we are going to see with the massage. With the placenta, we are not going to go for the massage. The first response PPH bundle must be implemented at both the primary health care and the hospital level. These are all the simple procedures which can be done even in the primary health center care. So this is the FIGOS and the WHO, so e-motive bundle. Who can do it? Everyone can do it. Immediately postpartum, every 15 minutes for the first hour. Every 30 minutes for the next hour. That is the massage we are going to do. How does it help is encourage the uterus, continue to contract and prevent the PPH. Next comes the, now we have seen the early detections, the massage is done. Oxytocin. This oxytocin already I told 10 units we are going to give IM immediately after delivery. Otherwise, we can go with the, if the PPH is present means 20 units can be added to the drip, and misoprostol, nowadays 600 to 800 can be kept over the rectum. Now we are very fond of this carbitocin because the carbitocin is the one which can be maintained in the room temperature. Like oxytocin, it doesn't need that it has to be maintained in the fridge. So the carbitocin is nowadays used and it is very, very helpful. So always uterotonics, oxytocin as part of the first response to the bundle. Call for help. This is the first method we are using, the call for help and the uterotonics. Then comes the T, the tranexamic acid. Nowadays, the tranexamic acid is included and it reduces by 20 to 30%. The FIGO recommends administration of tranexamic acid 1 gram. That is, as soon as the diagnosis of PPH is made within 3 hours of the postpartum. So within the delivery, within 3 hours, if you are going to give this tranexamic acid, it reduces the PPH by 20 to 30 minutes. So it has to be given intravenously over 10 minutes. And the bleeding will be stopping. And if needed, we can repeat this after 24 hours. So the early detection, massage and oxytocin, tranexamic acid, then the IV fluids. This IV fluids is very, very important. This is the pin grid. That is the head end one should see, and the arm end one should be present at the perineum. That is simultaneously. The head end person will see the check airway, breathing, administered oxygen, sublingual misoprostol. Most of the time we go with the rectal misoprostol. Sublingual misoprostol, if the patient is unconscious, we are not giving. So the keep the patient flat and the reassure the woman no times of the relevant events get data. In the arm end, what it happens in the both end, we have to give the IV access and send the samples. If the bleeding is more, means sample for the coagulation profile, complete blood count, what is the component of the blood has to be given, whether whole blood has to be given, plasma volume has to be given, platelets has to be given, or whether the fibrinogen has to be given, this has to be produced. On the other hand, you are going to give the oxytocin. And the mechanical methods like bimanual compressions, IoT compressions, that can be done. And the perineum, always massage the uterus, coordinate with the helpers in the head and the arm, and to catheterize the bladder. The first PPH is first catheterize the bladder. And the atony, bimanual compression, Foley's tamponade, sometimes if needed. Now we have the Foley's tamponade. That bug grease balloon is not available everywhere. So with the Foley's, you tie a condom and it can be applied inside and it can be used as the balloon method. Nowadays, from south, we have that suction cannula also, Panicure suction cannula, that can be connected to the negative pressure like vacuum apparatus, and you can have the suck all the blood, and the bleeding will get stopped, and then the cannula can be removed. So this is the simultaneous pin grill, head end, arm end, and the perineum. So the importance of IV gauge, what is the type of IV gauge has to be given, and what is the gravity flow, what is the flow has to be done. If the 18 gauge means 250 ml per hour, 16 gauge means 350 ml, depending on that, we have to see what is the color of the gauge we are using. So the PPH emergency response comorbidities is, as I told, the first response bundle, that is the administrations of the kits. All this PPH kit should be always available. Then comes the misoprostol Renaxamix, which we have discussed, and this non-pneumatic anti-shock garment. That is also nowadays used. Suppose the patient has referred from the primary health center, where the bleeding is more than 1.5 liters of blood loss is present, means from the primary health centers, they apply the non-pneumatic anti-shock garment and send the patient. It has 7 components. I will show this and come back. This is the non-pneumatic anti-shock garment. That is 1 at the ankle level, 2 below the knee, 3 above the knee, 4 at the pelvis, and 5 will be in the uterus, and 6 will be like a ball. So simultaneously, both the side, one person should stand and they should apply. So when you remove also, you remove in the same way. It cannot be when you refer to the higher centers, immediately they will not remove. That anti-shock garment which is available there will be given to the primary health center. And once the BP has recovered only, this has to be removed. Again, 1, 2. In the same way, we have to remove. Once the 1 is removed, again see the BP. If it is normal, then remove the 2. If it is not normal, again apply the 1. It can be kept even for 24 hours till the patient is getting stabilized. That is the anti-shock. It should be available in all the non-pneumatic anti-shock garment. It is available in all primary health center and the district hospitals, and even the teaching hospital. E is the examination and escalation. That is the evacuate the bladder, catheterization, evacuate the clots, examine the genital tract, rule out any tear, which I told, vaginal and cervix, whichever is present, and examine the placenta for completeness. This is the escalation. So this E motive has to be done simultaneously, which that the 20 to 30% of the PPH mortality can be reduced. So these are all the other methods which I told, the IOT compression, bimanual uterine compression, keep the right hand over the vagina and the left hand over the abdomen, and give the posterior fornix continuous compression for 5 minutes. Just like that you cannot do. Just keep for 5 minutes. And if it is a thin patient, means the IOT compression can be given, and the balloon terminate, as I told, with the Foley's catheter, the tip can be cut and condom can be attached, and it can be put into the uterus, and with the IV fluids, 400 to 500 ml of fluid can be kept, and it will be between the anterior and the posterior surface of the uterus, and it can be kept for 24 hours continuous. So these are all the methods. The IOT compression, which I told, if you are going to give the IOT compression, femoral pulse will not be seen. So this is the way if we are reducing the blood flow to the uterus, this and all can be tried. But all these methods has to be done within 30 minutes. You cannot take your own time. Whatever the bimanual compression, medical methods, IOT compression, everything should be tried. If it is not going to control with all these methods, you have to shift the patient to the theater and then go for the surgical methods. This is the Bagri balloon, which I told. This, if it is not available with the catheter, you can apply the condom and rush with the IV fluids. This non-pneumatic anti-shock garment, already I have explained. 1, 2, 3, how we are going to apply. 1, 2, 3, 4, 5. This 6 will be like a ball, which will be kept over the abdomen, and it will be at the level of the umbilicus. This anti-shock garment is available everywhere. If it is not present, please avail. It can be used only for the pulse cori, BP cori patient, not for other patient. If you are going to use for normal patient, the patient will become frozen. So it can be used only if the pulse cori and BP cori, as I told, how it has to be applied. 1, 2, 3, 4, 5, 6 is the ball. In this way, the patient will be referred. And once the patient is recovered, it can be removed. Otherwise, it can no need to remove it. This is the condom, which I told. This catheter can be cut, and you apply the condom and introduce into the uterus and put the IV fluid. With everything, if it is not going to settle, then you go for the theater, the surgical methods. That is the B-line suture. B-line suture, one, you are going to take, if it is an LSES means, from the lower segment, go to this upper segment, go behind the uterus and take a bite in the posterior surface and go 4 centimeters again in the opposite side and come out the fundus, come into the upper segment, lower segment, and then tie it down. This is the B-line suture. There are many sutures are there, Hyman sutures and Gunsila sutures, whatever it is possible, try it. It is just like a putting the knot. So these sutures can be tried, and you try stepwise ligations, uterine artery ligations, by internal iliac artery ligations, everything can be tried. But even the surgical procedures which has to be tried within an hour. If it is not going to settle, the final is only the hysterectomy. The medical management and the mechanical management has now reduced the obstetric hysterectomy. So now the first identify the case and then go for the treatments. In the meantime, you have to keep ready the blood and blood products, whatever is needed. The PRPC, FFP and PLT should be applied in 1:1:1 ratio. That is the multi-component therapy. Simultaneously, whatever the blood loss has been given, that it has to be compensated. This is the method which I told is the panicus cannula. This for vaginal and even for the LSES. This cannula with the serrated opening end has to be inserted into the uterus, and this end you can apply to the negative pressure like vacuum apparatus. When you give the pressure, it will suck all the blood, and once the bleeding is stopped, it will you keep the cannula just like that, and automatically it will be removed. With the cervix, don't try to remove it with force because cervical tear can happen. So the take-home message is e-motive, early detection of the PPH and treatment using WHO first response bundle. This is the e-motive. Use of a calibrated rate of detection if possible, and the bundle of treatments which I told, that is the examination, massage, oxytocin, tranexamic acid, IV fluids, escalation. Escalation which includes tone, tissue, trauma, what are all the causes that can be done. Oxytocin and tranexamic acid, escalation of PPH, 60% of the reduction in severe PPH. So the median blood loss, the need for postpartum blood transfusions, and the number of maternal death also has been reduced. So this is the e-motive bundle which we have discussed. Once again, I request all of you to support me and vote for me. The voting time is August 1 to 10. All of you make all your friends also to vote for me, such that we should win and become the academic partners in the FOXY. Thank you. Thank you for this opportunity. If any doubts,
Thank
you
you,
can
ma'am.
mark in the chat box.
Yes, ma'am.
Yes,
Surabhi,
Madhumita.
ma'am, your closing comments, ma'am. Surabhi, ma'am.
Surabhi, you can unmute and tell.
Unmute, please unmute, ma'am. I think ma'am is in the hospital. I think she's busy. Okay, ma'am. Yes, ma'am.
Dr. Rita?
So, Rita, ma'am,
This also
the video is off, ma'am. I think we'll go with the
We'll
next
go with
session.
the next one.
Rita ma'am's video is off.
Oh, no, now
So
she is
moving
there.
on to the next session, we have a
Dr.
very
Rita,
interesting.
would you like to give some any comments?
Yes, ma'am, very well presented. The PPH is really a nightmare for all of us, and you presented it so nicely and so precisely. Thank you so much, and wish you all the best for
Thank you.
your further forthcoming elections. Thank you.
Thank you, Dr. Rita. Thank you.
Thank you so much,
Thank
ma'am. Thank you, ma'am.
Yes, madam.
Yes, ma'am. So moving on to the next session, we have a panel discussion on HDP, moderated by Dr. Priya Kannappan, who's a senior consultant at Mehta's Hospital and GFC Fertility Center at Chennai. She's also the executive committee member of OXY and the South Zone coordinator of Quiz Committee of FOXY. And she's a master trainer of FOXY HPV vaccination training program. And we have our expert, Dr. Rekha Rajesh, who's the president of Krishnagiri Society of Obstetrics and Gynecology, and who's an infertility consultant. Next slide, please. And we have a panelist, Dr. Meena Mahalingam, who's the immediate past secretary of OXY and also the executive committee member of OXY, who's a urogynecologist. Next slide. Dr. Sunita Samal, who is an obstetrician gynecologist from Apollo Women's Center at Chennai, and She has numerous awards to her name. Next. Dr. Sunanda, who's an infertility consultant from
Yes.
who's an infertility consultant from Salem, and she's a fertility specialist, and also she's also skilled in obstetrics, high risk obstetrics. Next slide, please. Dr. Rahul Anand Kanagasabhabati, who's a PhD research scholar from Annamalai University, and whose area of interest is obstetric medicine. Dr. Mahajabeen, who's working in who's currently an associate professor at Sri Lalitambika Medical College and Hospital, and who's a member of OXY. And we have Dr. Pavitra, who's a consultant obstetrician and gynecologist from Salem, and Dr. Shri Abhinaya, who's an executive council member of SCOT and also OGSOS. Welcome, dear panelists.
Priya, how many members are there? Dr. Mahajabin is there.
Yes, ma'am. Dr. Sunita Samal is there. Dr. Meena Magalingam is there.
Dr. Sunanda is there.
Yes.
I am there, madam.
Yes, Dr. Rahul is there. And I think Dr.
Shri Abhinaya is also there.
Yes, Shri
Dr.
Abhinaya.
Pavitra is there.
Pavitra is there.
Okay, all are there.
I think everyone is there, ma'am.
Yeah.
Okay, Priya. Then
So I will share my screen. So a very good evening, one and all. So it is my pleasure to, be a part of this wonderful academic session. And I welcome all my panelists. I have not named any of the questions to anyone. So it will be nice that, you can take the questions. So today we are going to start about hypertensive disorders in pregnancy. So one of you, I just wanted to say how to classify hypertensive disorders of pregnancy.
Yeah, hi Priya.
Yes, ma'am.
Yeah, so hypertensive disorder you divide into like a gestational hypertension, then chronic hypertension superimposed on preeclampsia and superimposed chronic hypertension, and then eclampsia preeclampsia syndrome.
Yes, ma'am.
These are the broad classification of like hypertensive disorder in pregnancy.
Okay, so anyone want to tell about what is white coat hypertension? Do we really have something called as that in pregnancy? Or do we just tell, like, so if normally a patient comes, a single value of 140/90, then we just reassure them, telling them, see, because you've seen me as a doctor, you're getting this. Otherwise, okay, just go calm down, relax, go home. But is the same, is it for pregnancy also, we put it as white coat, or do we care for them also?
Definitely no, ma'am. Even a single value more than 140/90 carries significance in pregnancy. So they require close monitoring. We might have to repeat the BP, and she requires monitoring.
Yes, so even with that, we would aim it as gestational hypertension. Sometimes they may not require antihypertensive therapy, but we give them that name only once it is there. So this 20 weeks is a cutoff to say for this one, like preeclampsia, gestational hypertension. So, like what is the exact value do we divide hypertension? Anyone? What value?
BP more than 140 by BP more than 140/90 millimeters of mercury. No?
Yes. So if it is before 20 week, we call it gestation. Call it chronic hypertension. After that, we call it as gestational hypertension. Yes. So anyone can tell me what is the definition for preeclampsia? Dr. Meena, you started. So can you tell me what is the definition for preeclampsia?
It's just a multi-system disorder beyond 20 weeks when we have a BP more than 140/90 mm of Hg. We do call it as preeclampsia, and we do check for urine albumin. When the urine albumin is present, it is preeclampsia. So it is not only the BP, it is also the proteins in the urine. So in the OPD itself, we check the urine for proteins and the BP. Then name her as preeclampsia. Nowadays, we classify it as non-severe preeclampsia and severe preeclampsia. Non-severe is when the BP is alone raised without any premonitory symptoms. In severe preeclampsia, the women will have not only the BP, which is more than 160/110 millimeters of mercury, there will be premonitory symptoms like headache, sensation of vomiting, nausea, vomiting, or blurring of vision, or upper abdominal pain, and also abnormal parameters, lab parameters may be raised.
Okay. So,
But,
Dr.
Yeah, so
yes, ma'am.
even in the absence of proteinuria,
Yeah.
like in absence of proteinuria nowadays, it is not necessary to diagnose. Absence
Yes.
of proteinuria, if the clinical features and the biochemical and the PP is more than 160/110, you can classify
Yes.
as a
So
preeclampsia.
whenever, yes, I
Here, just one
completely,
thing I want to tell: this
yes.
gestational hypertension, is it 12 weeks postpartum or 6 weeks postpartum?
Sorry, ma'am, it is wrongly written here, 12 weeks.
Yeah.
Yes,
Okay.
sorry.
Thank you.
With the
Also,
old PPT, we didn't get it
So
corrected.
as per
Recently, we
international,
are putting it as 12 weeks. Yes. Sorry,
yes,
Dr. Majubin.
yes, ma'am. As per International Society of Study of Hypertension in Pregnancy, now
Mm-hmm.
the proteinuria is not at all mandatory to
Yes.
diagnose
Preeclampsia. So that is what
preeclampsia.
has been highlighted by
Hypertension.
Sunita madam. So
Ah.
whenever you have hypertension along with multi-system disorder, maybe your liver is involved, maybe you have a brain symptom, maybe you are having an epigastric pain, either your imminent symptoms or you are having your low platelet, your PT-APTT is raised. So any of your lab parameters are there. Even in the absence of proteinuria, it is still called as preeclampsia. And Dr. Rahul, so can you comment on FGR with gestational hypertension? So what do we classify them when a patient is gestational hypertension and the baby is a FGR? So does it change the classification? Dr. Rahul, are you with me? Yes.
Yes, madam. Yes, madam. Yes, madam. I would still, because when the placenta is involved, we also consider the placenta as a separate organ by itself.
Yes.
So I would like to upstage the classification into preeclampsia.
Exactly. Very good. So it is whenever your placenta, so any end stage disease or any organ involvement, and placenta and the baby are another organ which is there involved. And if there is an FGR, it automatically upstage and go as preeclampsia and not the gestational hypertension. Wonderful. So I think, can someone take up early onset, late onset? So what is the cutoff? And what
Early
is the
onset is less than 34 weeks. If the patient develops like hypertension or preeclampsia, it is early onset preeclampsia, and if more than 34 weeks, it is late onset.
Okay. So anyone want to say what is the important? Why should we classify early or late? Anytime, let it come now.
Because
Associates to delivery.
Early onset preeclampsia are more commonly associated with adverse placental outcomes. Late onset, we are worried more about the cardiovascular risk factors for the mother, continued risk factors, risk associated with the
I beg to differ in that. Is there any
Early onset, then the complications will be more for the mother.
Yes.
Severe
Complications are
maternal
more, your
complications as well as
cardiovascular outcomes and difficulties are more with early onset, and late onset are relatively a little lighter disease. They don't go and give you much of complications. That is what we see in clinical practice. Anytime severe preeclampsia, we're not talking these early onset and late onset are more than that. Earlier they come, they land up with complications. So that is why we don't wait till term for the early onset preeclampsia. Most of the time they go and get into some complication on their own, needing delivery. So something or other happens for them. So
and early onset preeclampsia also, it may be associated with APLA. Because in APLA, in the obstetric criteria,
yes,
one of
Dr.
the
Sunita,
criteria is
you
early
have
onset
put forward that.
preeclampsia.
So other than APLA, what else are we thinking of that? Sunita ma'am. APLA,
Pardon
yes.
me?
Anything else other than APLA?
Maybe patient is having a chronic hypertension, patient is
Yes.
having a GDM, any chronic liver disease, renal disease, all those
Yes,
chronic
so more of
conditions also
diabetes,
can give rise.
including
Yeah.
vasculopathy, those kind of patients, even SLE they will have. So anyone having a chronic disease involving the kidneys or a severe form of hypertension, these patients tend to have a early onset. And suppose if it is like 20 week itself, that is very severe hypertension, then we tend to evaluate and start investigating for one of these diseases as well. So can someone
also to add anything like any other secondary causes of hypertension, if it is evaluated, we could also think of early onset preeclampsia and autoimmune, all the autoimmune conditions we need to think of.
I completely agree. All autoimmune come into that. Okay. Can someone tell me what is atypical preeclampsia?
She will not have proteinuria, but other symptoms like as
Yes,
you
sometimes
mentioned,
they cannot even
IUGR.
have high BP. They'll have only 130, 90, but still they will be sitting with health syndromes.
Yeah.
So we'll not be talking about eclampsia. I think we'll be all knowing that having a seizures during pregnancy. And what is the specific tagline we give for eclampsia? Anyone? A tagline. Eclampsia means this one.
Lightning.
Yes, no. Any seizures in pregnancy? Anybody want to
Unless proved otherwise.
Unless proved
Yeah,
Yeah,
otherwise.
unless proved otherwise. Yeah.
Yeah,
All my
any
family
convulsion
doctors
during
can tell that.
pregnancy should be considered as a eclampsia.
Any seizures in pregnancy. So, and now we'll go to mortality. And
Priya, you are not audible.
Your connection is lost.
Priya's connection is unstable, I think.
sorry, I got disconnected. I really thought nobody else is answering. And then only I understood my network was going on. So sorry, I'm sharing my screen. Can you hear me now?
Yes, you're audible.
So Dr. Rahul, can you take up this question? Maternal mortality and hypertensive disorders in pregnancy. Any comment?
Hypertensive disorders in pregnancy per se do not have a very defined, universally accepted maternal mortality rate. It depends on the ethnicity of the patient and also the type of quality of antenatal care which she is receiving and where she is actually delivering. So overall, when compared, the case fatality rate associated with the pathology of hypertension is only 0.5% in well-resourced settings. However, in lower resource settings, it can be anywhere between 1 to 5%.
Okay, so anyone wants to add anything or anything else you want to?
Basic thing in a maternal mortality we need to think of as a national or a state level is anemia, hypertension is a deadly combination.
Yes.
Among the topmost 3 causes, the death is because of one is postpartum hemorrhage, as madam has spoken in detail. The next thing we need to think of is a hypertensive disorder of pregnancy, and the third thing we need to think of is sepsis. These 3 things are the most important cause for maternal mortality. And anemia, if it is present with preeclampsia, it is going to be a deadly combination.
Because they are going to cause cardiac failure there together with that.
Yes.
And one more thing, I agree with you, Dr. Rahul. Yes, hypertension per se doesn't cause the death. And also, one point we all agree, timely interventions will prevent death. And if you take a little bit of liberty of waiting, we are going to land up with maternal mortality. So that is the point which we want to emphasize. And that is what we meant with institutional delivery, because in the institution, we have a timely intervention. And if you say, wait, it's okay, help only, no, today is Ashtami, tomorrow is Navami, day after tomorrow, shall we deliver, and all those things, if you wait, we are losing the patient then and there. By the next day, we are losing the patient. So those are the things where you have to intervene and not listen to the patient in these situations. So fine. So can someone just take up the question and tell me about the pathophysiology? Like what are the theories which is coming up with pathophysiology of preeclampsia? Anyone?
Faulty presentation of the
Yes,
placenta,
Dr. Pavitra, yes.
excessive trophoblast invasion, and along with the maternal vascular disease of any pre-existing, all leads to the genetic, immunological or inflammatory cytokines release. And along with that, there is a reduced uteroplacental perfusion leading to endothelial activation, and which further causes multiple organ dysfunction, along with the features of preeclampsia that we may see visibly as edema.
Very beautifully told. So you told us both the theories. One is trophoblastic invasion. The second one is inflammation and the generalized inflammatory reaction causing a multi-system failure. Dr. Meena, you wanted to add something?
Yeah, yeah. One word, if you want to say pathophysiology for preeclampsia, eclampsia is vasospasm. So vasospasm is the pathology, that is the vasoconstriction. So the definitive treatment will be termination of pregnancy. With one word, you say vasospasm or vasoconstriction.
Yes. And if you want to rephrase it or say it, it is the placenta causing the disease. take out the placenta, your disease is going to go. So that is what is the pathophysiology in most of the cases of these kinds. So anyone want to like add up something on prediction, prevention? So first we'll stick on with prediction. So Dr. Sunanda, you want to take on prediction? How can we predict preeclampsia?
With the third first trimester screening, we can do preeclampsia screening, ma'am.
Yes.
The pregnancy associated plasma protein value, with that we can also predict whether she will get the hypertension.
Okay, so what is the
And prevention we can add, if on the uterine artery PA, if it is more than 95th centile, we can add ecosprin 150 from 12. Before 16 weeks, we have to add. Then only it will be efficient.
Okay. So anything else can we do? Like one you have told me about.
Romella test.
Okay.
Calcium and fibronectin estimation through a
Fetal fibronectin, are you sure about preeclampsia? Because it prevents preterm, predicts, yes.
It's preterm labor, I feel, fibronectin.
Usually we don't have it for fetal fibronectin, but it is something else. So anything else?
Placental growth factor.
Testosterone score
Placental growth factor,
to
PLGF.
identify the
Placental
risk.
growth.
Yes. So Dr. Sunanda, you were saying about
Placental growth factor, PLGF estimation can also predict.
And Meena, we are coming back to you. I'm coming back to you for the gestation score. So let us finish the blood test. We are hi-fi now. We are going to come back to basics later. So yes, I agree. Gestation score is now recommended. And when do you want to put the gestation score? Dr. Mahajubin, you want to answer that. When do you want to put the gestation score?
Gestosis score, in the initial visit itself, we have to ask for the history. But the main thing is, gestosis score is more towards the history and the mean arterial blood pressure. So as per the Fetal Medicine Foundation, they have included the maternal history, mean uterine artery Doppler, placental growth factor, and the, mean something I missed, low PAPA. All these
is also included, yes.
Yes, ma'am. All these they have included in Fetal Medicine Foundation. As per Fetal Medicine Foundation, though this will increase the prediction of preeclampsia more, but anyway, gestosis score is more important because we are more concerned about the history.
Yes, I agree with it. So now I'm coming back to you, Dr. Rahul. So you work with the little bit of low resource setting. So we are coming there. Actually, like I'm not sure about other people, but I know Dr. Meena and Dr. Rahul are in the government setup, and Meena is in our city, and Dr. Rahul is little more in the peripheries. So, like are you equipped with PAPA for all the patients, Dr. Rahul?
No, madam, we are not, and I don't think anywhere in the public sector we have PAPA right now.
No,
So we would
in
move.
Chennai, we send it outside. So patients themselves get the Down syndrome screening. FTS, they get it and come back to you. So all patients, they do it and come. So in Chennai, like, I can tell you for even in government sector, all the patients go out for Down syndrome screening, and most of the lab combine PAPA and give it to them. So, whether you want it or not, it is given to them. So maybe if you say about a PLGF, I agree. Yes. So what do you do, Dr. Rahul? In your setup, low resource, where we can't even do a PAPA. Dr. Rahul?
No.
There comes the gestosis score.
Yes.
Yes.
So there you have to rely more on your history.
Yeah,
gestosis score, it is a wonderful thing. So prevention, I think already we have mentioned about ecosprin. So is there anywhere else you want to start early?
Previous history of
in previous history of GDM.
Yes.
Previous history of PIH, especially PIH, or in twin pregnancies, in IVF pregnancies.
Yes.
No, in twin pregnancy, that is actually for the start the ecosprin. We have a high risk factor and the moderate risk factor. In the high risk factor, when you see the patient is itself, it is a diabetics, previous history of any chronic renal disease,
autoimmune.
All those things are history of either any gestational hypertension, preeclampsia, or eclampsia. There you can start even the once 6 weeks, once you see the cardiac activity is there, immediately you can start the ecosprin. No need to wait till 12 weeks in high risk patients.
Anybody wants to give low molecular weight heparin for prevention of preeclampsia?
No.
Anyone?
No.
No,
No,
madam.
as per guidelines, it is not recommended for that. So, see, actually, only in our neighborhood, we start low molecular heparin for IVF pregnancies, but most of the, all over the nation, they are not doing that. So, it is not as per recommended. So, for prevention, only that. And anyone gives this one, calcium tablets for preeclampsia, because we know low calcium can cause that. So, anyone giving calcium supplements can prevent it. Anyone believes in that?
ACOG recommending 1.5 to 2 gram of calcium.
The gram of calcium.
Yes, but we don't recommend, like,
We
we don't
won't.
start off with the early weeks. That is what
Even
I.
if they take- Yes, ma'am.
Yes. So yes, the uterine artery Doppler, which is more easier. Anybody with the scan machine, you can do the Doppler yourself. At least you can get that. And first trimester cost effectiveness, they've already told that. So any private sector, most of us are doing the Down syndrome, and your PAPE is a part of Down syndrome. Yes. And for the public sector, I mean, still we have a gap in that. For them, gestation score and the uterine artery PA is what they rely on. Dr. Rahul, do you do the uterine artery PA for all patients?
Yes, madam. We send for the uterine artery PI.
Okay, lovely. So, and this is about low dose aspirin. Sorry, these are
Even yeah, even the simple mean arterial pressure itself, that will also is like a
yes.
predictor in the first
Actually,
trimester itself.
in
Yeah.
a recent this one, the government's advice, madam, what they have said is there is a raise in BP by around systolic 30 and diastolic of 15. That itself is a predictor for preeclampsia. For example, her booking visit is 90/60, and then next visit, if she is increased by 30,
20.
even if it is only like 120, it is still normal. But if it is 125/85 or something like that, then you should think that this patient is going in for preeclampsia. So those
Actually, this definition, when I was doing PG,
yes.
in the Arias, Fernando Arias book, it was
Madam,
there.
even when I
Systolic
was
rise
doing,
in
it was
30.
there, madam.
Yeah, yeah,
It
yeah.
was there till I think 2012, 13, it was there. I think now it is not there at all.
Not there.
That
Yeah.
increase in the blood pressure as a definition for preeclampsia is still not there. But the government is emphasizes to look into these patients. At least you call them for follow-up and monitor them. They have a tendency to go into preeclampsia.
Correct.
Ma'am, one more thing about that glycosylated fibronectin I have told you. That is a point of care test. Like a UPT, you just want to drop a serum over there, and if it is a double line, that is a predictor of preeclampsia. There is already there. That is in foreign countries. I don't know how far it is in India.
I've never seen in our
India,
guidelines.
it is
Sorry, I'm
not there.
having an idea.
We are not.
Because in our thing, we
Even
don't do.
fibronectin for preterm labor, we talk,
We are
we
not.
do not do.
And
Correct.
that is
That
on
also we don't do.
cervical secretions having a fibronectin again for that for preterm labor. Because we don't have that kind of facility. That is what I feel. Even in the well-resourced setting to do a fibronectin test. So that is where. And again, your SFLT level or your SFLT by PLGF levels are mostly in trials. Some of the hospitals are well equipped. Okay. In our setup, we still do that. And that again gives you a different scoring for preeclampsia. It gives you two types of scoring. A chance of getting a preeclampsia at 37 weeks and a chance of getting preeclampsia at 32 weeks. So it gives you the, like a score that it can predict early onset preeclampsia. So those patients you will have a more closely watch for that. So that your SFLT PLGF ratio gives that. And definitely lifestyle measures we are going to say. And Dr. Meena, you were telling about gestosis. So something very important, something which you really felt very useful. Just tell me something short to remember in this score. Some points.
It's very difficult to remember actually.
Yes.
But main thing what we have is the assisted reproductive treatment. Those women, if they have that alone, one single criteria itself, they fall at a high risk for having a hypertensive disorder.
So what is the
Either
score
a
we take to start tablet? Ecospirin. A score of 3.
3.
3, exactly.
Just with that one score, yeah. If it is ART pregnancy with that one score, or APLA pregnancy, or if there is any secondary causes for hypertension like chronic kidney disease or acquired thrombophilia, which we generally do not do as a routine, and mental disorders, chronic, yeah, these are significant
was
because
actually striking because that gave a score of 3. So any patient is schizophrenic, she's taking any antipsychotic, the automatically her gestation score goes to 3 and she falls under the category to start off on that. So at least we should remember the score 3 criterias. And again for IVF, you have to always ask, is it the own egg or the donor egg? And if it is a donor egg, then they automatically fall into score 3. So these are the things. And definitely if you have obesity along with elderly women and an anemic women, so then all the 3 together, that comes to score 3. So remember these things. So always take this chart, work up on a score. And if it is high risk, start her on aspirin then and there.
I'm having a question regarding the mental health disorders. What about OCD, ma'am?
It doesn't, actually they have not defined, they have
OCD
defined
doesn't come.
about this one.
Schizophrenia.
Yeah, and like OCDs, unless and until you have a psychiatrist to define that, we cannot, put it as OCD, because I feel most of us even have that symptom. Okay, a little bit of thing which is normalized, and only when they go above the edge, it classifies to a psychiatric disorder. So, I think we should not take all the diseases like that. See, many patients come back to us and tell us, I am having depression. It doesn't classify as a major depressive disorder unless it is being qualified by a expert. Okay, so I think we should take it with a pinch of salt. Rather than a patient classifying her as a disorder, we should wait for the expert to give us a diagnosis. So let us go with the cases. Primey, 150, 100 BP. She's come to the OPD, no other complications. You just put this one and she's having the BP. What is the management? So anyone? Dr. Abhinaya,
what is the weeks? Gestational age?
24 weeks.
So
We have to repeat the BP.
I'll check
We have to
her
repeat the
previous
BP again.
So you're repeating the BP. How many hours?
15 minutes later, 15 to 30 minutes later, we can
Want to
repeat
repeat
the
in
BP.
15 minutes?
4 hours.
4 hours. Usually we ask them to settle down. We ask them to wait. And before waiting, any specific instructions you give them?
She should rest well. She should not be anxious. Don't drink any caffeine.
Most of the time we say at least in a sitting position. And your proper BP measurement with your arm supported sitting position and all those things, we make sure that the BP is there. And we usually repeat it in 2 to 4 hours time. Usually 15 minutes is because of the first value of very high. When she doesn't have imminent symptoms, I don't think we'll go immediately and repeat it in 15 minutes. Unless and until a patient has an imminent symptoms. Yes. So once you repeated it, the BP is again 150, 100. What do you want?
Start her on antihypertensives.
So what do you want to start?
Ma'am, I would admit
Labetalol 100.
Lovely, doctor. I agree with you.
Yeah.
You want to admit her or you want to
We
do?
generally admit in the government sector and do all the basic investigation, give a tablet labetalol and wait for the investigation
I have got 2
results.
people from the government. They say they want to admit and do all the bloods. So now from the private side, I want a, opinion. Want to admit. Patient is just come for OP. Chumma in the doctor vanda admission is solidum. She'll tell you that. Always when I come only, this doctor will find a reason to admit me.
At 24 weeks, having a BP of 150, 100, we need to admit, otherwise the patient will be lost for follow-up with the
at
tablets.
any point in pregnancy or postpartum with BP 150, 100, we'll admit.
Okay, fine. So, Dr. Rahul, point taken. Any point of pregnancy, she's pregnant, but BP, admit. Okay, come on, private people. Dr. Sunita, madam, what is your opinion? Admission costs, it's not free here. So, you have to tell.
We'll say at least we'll observe her for 12 hours at least. Whether the BP
At
is
least you
reducing
will
or it is
suggest a
increasing.
daycare admission. Okay,
Yes, ma'am.
Dr. Sananda, I agree. So, Dr. Majubin, what do you want to do?
Yes, ma'am. For observation, we can just observe her for the antihypertensives and we can send for all investigations.
So
and
send
she
the
can
blood.
do home BP monitoring.
Home BP monitoring. So anybody differs with these things. So I think my panel has agreed. If you feel your patient will lose follow-up, you're going to admit her and do the bloods. If you have a compliant patient, you know that the patient is going to be with you. You will observe for a few hours to see whether the BP comes down with the antihypertensive, but you will send the bloods and then try to send the patient home. So points taken. Anybody differs, or are we going to the next round? Next question. So I think we will go. Everybody agreed with me. It is gestational hypertension, but we have to rule out preeclampsia. So we are sending the bloods. We are starting on Labibet. Okay. So then they have done, like at 20 weeks, there was nothing. She was normal. The growth was normal. There is no problem at all. And then I think she just delivered with us and no problem at all. So what are the antihypertensives in the pregnancy we have?
We have only labetalol, methyl dopa, and nifedipine. When we were postgraduates, we were giving alpha methyl dopa by ourselves, give the patient water to drink and check the BP again.
Why
Now
does this
with
drug
this
leave us?
labetalol,
Initially, we
yeah,
all had this drug.
yes, because of the symptom of Coombs hemolytic anemia, that is what is being said. And postnatally, the women just goes for depression. That is why they have stopped the drug. But now we have started to use only labetalol and nifedipine as a second line of treatment. So labetalol, we start as 100 mg tablet once a day or twice a day, or just go till 200 mg TDS. Even till 1200 mg, we can start in divided doses and basically monitor the BP regularly. And if it is not controlled with one labetalol alone in the highest dose, we can just start nifedipine also as
Till
10
what
mg.
maximum dose you go with the Labibet? So anyone wants to take it?
2,400.
1,002.
Actually, the textbook says 2,400, which is nothing but
1,200.
800 milligrams.
1,200 practically we can give, ma'am.
Yeah, but we don't go up to 800 milligram 3 times a day. I've never seen anybody's prescription there. And most of us, we stick on with 1,200. And even with that, if it is not controlling, then we add either an nifedipine or we try to deliver her if she's gone beyond to a level. So now we come to a second case, a second gravida. Now she's at 32 weeks. She is on antihypertensive since 4 weeks. So this is an early onset preeclampsia patient. I mean, early onset gestational hypertension. From 28 weeks, she's been on antihypertensive, well-controlled home BP monitoring are fine. Now she's complaining of headache, blurring of vision, and but however, the gestational age on examination is corresponding to the 32 weeks, and BP is 170, 110. What do you want to do? Second gravida.
I will
Admit her, madam.
admit and I will
Admit.
Admit.
I love that.
In ICU.
Rahul, everybody admit. I really love that because that is more important. Yes.
Admit in ICU. Get
Both the hypertensive
detailed counseling. IV labetalol,
management
strict
for
monitoring
to
of BP
investigate.
and
So what
magnesium
are the three
sulfate.
journals of management for this patient? So one of you, Dr. Sunanda, you wanted to answer. Yes.
Admit. We have to admit the patient, give IV labetalol, and we have to investigate her whether she's going for HELLP syndrome. And then we can give magnesium
We should
sulfate
start
for prophylactically.
Okay. And?
And give her
We
steroid
can do
also.
steroid coverage for
coverage.
in case she needs for delivery.
Okay. So
Three-pronged approach
actually,
we will do,
now the
madam.
management
General
is
measures,
close
obstetric
monitoring.
measures, anti-seizure medicine.
Exactly. So we want to control of hypertension. 2, prevention of seizures. 3rd is to deliver. Any patient, imminent symptoms and signs, we are not going to wait any further. You want to deliver. Correct? Do my panel agree with it, or anybody wants to say, no, I will see once the BP is come down, her headache will be better. I will continue till term, 37 weeks. Anyone
No,
differs?
madam.
No,
No,
ma'am.
no, no.
No, ma'am.
Everybody is decided we are delivering. So she is preeclampsia because she has imminent signs. Yes. Magnesium sulfate, steroids, termination. So how do we give the magnesium sulfate? So
There are two
So in
regimes.
the government, we are.
Dr. Pavitra, you want to tell? Yes.
Pritchard's regime or Zuspan's regime.
So what regimen do you use, Dr. Pavitra?
Zuspan.
So tell me your regimen.
First, we have to give the loading dose. The loading dose is 4 grams IV, followed by maintenance dose of 1 gram per hour infusion until we deliver. Or
So how do you give the infusion in your setup?
Through the pump.
Okay, so how much you load and how do you set up?
1 grams, 1 to 2 grams per hour. It has to be infused along with a syringe with a normal saline.
Okay, fine. So anyone wants to add anything to this? Any of my
So preparation of magnesium sulfate is very important. Each ampule, that is 2 ml, contains 1 gram. So we have to dilute. So 4 grams means 8 ml with 12 ml of distilled water diluted. 20% weight by volume solution is given for 15 to 20 minutes. We have to tell the patient that there may be burning sensation in the, especially the genitalia. That is the means to say that is the drug is taken as action. And then initially start monitoring for the respiratory rate, should be at least between 14 to 16, and urine output 30 ml per hour, and also the deep tendon reflexes. For the first dose, you need not worry about the presence of urine. Then maintenance dose, according to the Zuspans regimen, we set up the syringe infusion pump, take 48 ml and set it at the rate of 1 gram per hour. If there is a recurrence of seizure, we can increase the doses 2 gram per hour or repeat the magnesium sulfate.
Okay.
Basically, we need to monitor the chart and also check the BP and check for the symptoms and signs.
Okay. So I agree with that. So for Dr. Sunita, like, why are we monitoring the urine output?
Yeah, because you have to look for the magnesium toxicity. So because normally like it like 4 to 7 milliequivalent per liter, and because the first is the symptoms this one to go to the knee jerk, and then only comes the like respiratory toxicity and the renal toxicity.
Because the magnesium affects the kidney, or is it anything else?
The last one, so you should monitor every 4th hour.
Okay.
The
So
magnesium toxicity.
yes, I agree with that. So usually
Ma'am,
Magnesium clearance
magnesium
decreases.
per se is
I
not
agree.
nephrotoxic.
Yes, it
But
is not
we monitor
nephrotoxic. I was
urine
about
output
to ask you.
because
Yes. Yes, Dr. Rahul. Yes, go ahead.
magnesium sulfate per se does not cause acute kidney injury. The drug is not nephrotoxic.
It is
The
not
elimination
nephrotoxic.
route is by the kidneys. So we have
Yes.
to ensure that the kidneys
Its
are functioning
clearance will
properly so that we
decrease.
don't get the other side effects of magnesium, like the loss of like areflexia or respiratory depression or cardiac arrest. So in want of preventing from the other side effects, we just ensure that the kidneys are functioning properly so that the magnesium clearance is happening. So the clearance of magnesium from the serum depends on the functioning of the kidneys. So per se, the drug is not nephrotoxic.
Yes,
So
I agree with it. Magnesium gets excreted in the kidney. So you just want to be sure that the kidneys are functioning so that the magnesium doesn't accumulate in the body and cause further toxicity. So that is why your first dose, you need not have urine output at all, because that is not going to cause toxicity at all. But further doses depends upon your monitoring and toxicity. So as we told you, like, Dr. Meena given us beautifully. Dr. Rahul, do you give only Zuspans regimen or you use the other regimen?
No, ma'am. We strictly stick on to suspense regimen.
Oh, you don't put the Prijad regimen?
No, madam. No, madam.
Oh, lovely. So I think, but many people still in the north, they use the Pritchard regimen. Anybody in the south, any of my panel is using Pritchard regimen?
No, ma'am.
No. Okay. So, but still for completion, let me go ahead, because still whenever we do panel with North Indian, other delegates, we always encounter that, they give Pritchard regimen, because monitoring is comparatively easy, because IV, the toxicity is more compared to the IM regimen. We try to avoid that because the having an abscess, and it is a very painful injection. So that is why we try to do that. So it is 5 ml, that is 5 grams or 10 ml on each buttock every 4th hourly. That is your Pritchard regimen. Loading dose is the same for both the regimen. So there are other doses where, you can give a low loading dose. There are high loading dose. There are loads of regimens on that. But most of us stick on to this one regimen, which is 4 gram IV as 20% solution. The dilution has already been detailedly explained by Dr. Meena. And then we load the remaining, 24 hour. So 48 ml into an infusion pump, and we set it at 2 ml per hour for the next 24 hours or till delivery, whichever is the latest. So
even when you give the magnesium sulfate IV regimen,
yes,
it will give a neuroprotection and also
yes,
32 weaker,
like prevent of the
being a 32 weaker. Yes.
Okay, so fine. Yes, actually, like according to your ACOG and your RCOG, it says like for especially ACOG and FOXY, up to 32 weeks, you have to give Maxel for neuroprotection as well for the baby, not the mother, neuroprotection.
Yes.
And after 32 weeks, 32 to 34, you can consider Maxel according to the RCOG. And in this case, okay, even if
it is the mother who comes first.
Maxelf, it is because for seizure protection in the mother and
not
it is
for
not for
neuroprotection.
neuroprotection in the baby.
Neuroprotection in the
So,
baby.
but it is an
Yes.
additional effect. Yes, it is an add-on benefit for us for the baby to have a neuroprotection. Completely agree with all of you. So, and then definitely, so these are the things which should be there in the labor room. Your antidote. So that I will come to you. I'm going to come back when I'm asking the tray. So these symptoms we'll be monitoring. So all the pre-monitoring sign and Zuspans regime we are told. told that. So, and these are the complications which I think most of us will agree with it. So it can affect any this one. And can anybody comment about this hyperreflexia? Initially, we used to have, like, maybe when I was UG, they used to say hyperreflexia as a criteria to diagnose preeclampsia or eclampsia. Now it is gone off the criteria. So anybody has any idea about that hyperreflexia?
This is because of the increased central nervous system irritability, ma'am.
Yes.
Due to that cerebral endothelial dysfunction and edema, cerebral edema, there will be increased central nervous system irritability.
Yes. So initially when we were all UGs, it was a criteria to say that it can be one of the signs. Now it has gone off the criteria. So it's not more there. And headache is, yes, multifactorial. Proteinuria. So how do you monitor proteinuria in your setup? Anybody doing dipstick yet?
No, madam.
Okay,
Yeah,
no, oh, Dr. Rahul, I thought you will say, yes, doctor, I will catch hold of it and put everything dipstick. No,
No,
from
madam.
your setup also,
We don't have a 24 hours laboratory despite having 500 deliveries per month. So once our lab technician goes away, we have a tie-up with the private laboratory using the public fund, and then we get a heat coagulation done. So we don't do the dipstick anymore.
Very nice. So anybody else doing dipstick?
No.
No, even
No,
we.
most of us do the spot protein creatinine ratio.
Yes.
That is
So
easy to
what
do
is
because
your comment
24
on
hours
this
is
spot
sample also
PCR?
difficult.
Yes, 24 hours we are no more doing at all.
Yeah.
It is just for textbook. It is for those things. It is gold standard. All those things have gone. Nobody is doing 24 hours at all. So that is outdated now. So we all do only spot PCR. How do we correlate with the 24 hours urine? Spot PCR,
That is
how do you correlate?
spot protein creatinine ratio of 0.3 milligram per taken as 24 hours urinary protein more than 150 milligram.
More than 300, 0.3, exactly 300 milligram per 24 hours. So that is the cutoff to say proteinuria. So any cutoff of 0.3 PCR, we take it as preeclampsia. So that is there. And I mean, like even a single proteinuria, we all take it. And why should we know whether it is early or late onset? Any difference? So anything about prognostication. So can anybody just comment on that? Prognostication and severity in your own experience.
Usually early onset, they have a bad prognosis compared to the late onset.
What kind of bad prognosis have you encountered?
They have a severe IUGR, and we might have to deliver them early. Preterm labors, very early preterm is also
iatrogenic preterm we are going to do.
preterm.
Anything else you have encountered in your clinical practice, in your experience? I just want your experience, no textbooks. Anybody has encountered anything with these
Early onset, we have more maternal complications.
Okay.
Like preeclampsia, eclampsia, abruption, pulmonary edema, and AKI. But late onset, they tend to have a good prognosis.
Press also.
And early onset also, for the fetus, it can have a higher degree of fetal growth restriction than late onset.
Yes, so I agree with that. So I think anyone wants to explain about what is this preeclampsia tray. Actually, now it is there in all your manyatas, every training, even in your Foxy's high-risk pregnancy training. Also, we say every center should have a preeclampsia tray. So now what all should be there? Just taka, 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 taka. Then we'll go to the next question. Anyone?
Yeah,
so
should have the
whatever.
Yes, somebody else. I mean, like, some of the videos are off. I'm not sure who's speaking. So sorry.
So definitely from the basics, there must be good vent flans, IV fluid, IV infusion sets, magnesium sulfate ampules, and along with 20 ml syringe if possible for starting the loading dose. And then knee hammer to monitor the reflexes, and in case calcium gluconate also.
Yeah, so whenever you find that overdose, fine. So like now we go to the next case. She is a 28-weeker, gravidate to para 1, live 0. Okay, previous childbirth, she lost the child. It was a preterm birth and she lost the child there. And antihypertensive, now she had fits at home 2 episodes. And she's been admitted to you. There is one, she comes to your emergency casualty. She's having a 3rd episode of fit. Her BP is 200 by 110. How will you manage? So she's there in your casualty. She's having a fit there. or your
admit the patient immediately, get a high risk informed consent for the mother as well as the baby,
Dr.
and then
Meena, I will
give
stop you
a
here. Only you are there. You will first go and explain the consent now.
no, just we need to explain what we are going to do because the patient is a very high risk. We have to call for help, shout for help, and then take a investigation for all the pre-eclampsia, and then start labetalol, and also get ready with the max sulfur. We need help to do all the investigation workup as well as giving drugs, and also explaining to the mother and also to the attenders about the condition.
Okay, fine. So I will ask other panelists as well. So let me come. So anybody wants to add anything?
To clear the airway, ma'am, to avoid aspiration.
Again, you should not forget your ABCs. I agree with that. So what you're going to do?
Yeah, because patient is in such a condition.
Yes. So yes, ma'am. Yes. And here, okay, I think.
Yeah. So you have to maintain the ABC, means the airway breathing and the circulation. Yeah, patient you have to put in a bed and to prevent the aspiration, you have to keep the head and little up, and you can put it in the.
Yes, we are going to give a left lateral tilt so that we are going to prevent both aspiration. So, and as well as some oxygenation to the baby should be there, and definitely trauma protection. Yes. So, should we give anti-seizure medication at this point of time? If yes, why? If no, why? She's having a seizures.
Patient comes,
you maintain the.
No. So, Dr. Rahul, you told me no, but why?
The seizure to settle, because the neurological activity will eventually abate at some point of time. So before, while she is actively conversing, holding her hands and getting a IV access, venipuncture access secured, that will be more traumatic to the patient. It is not possible also. And even under and for 20 minutes, we have to give the loading dose, madam. So it will be very difficult that 30 to 60 seconds for that seizure to settle does more good in the long term. So I would stabilize her, do the first aid, and do the ABCD. After in the post-ictal phase, I start giving the seizure treatment.
I agree with it. The only thing about preeclampsia is that the seizures are always self-limiting. We are not talking about epilepsy or, status epilepticus. We are talking about a preeclampsia going in for eclampsia causing a seizures. Most of the time, they are self-limiting. So you need not give any anti-seizure medication at this point of time because it will anyway settle. So those are the days where we used to do diazepam regimens and other things, phenytoin. Now it is not much of role because Maxelf alone has been enough for us. And if it is Ogesian managing, it will be always Maxelf. But if you have a multidisciplinary and your physician or a neurologist come into play, there will definitely be a levetiracetam will be added to the list. So you cannot tell them not to add. Sorry, Majbin. Yes.
Yes, ma'am. Lorazepam. Yeah, if the seizure recurs even after giving magnesium sulfate, there is recurrent seizures even after magnesium sulfate, we can add second line drugs like lorazepam or diazepam.
Yes, I agree with it. If you have a recurrent seizures, then we are going to think of, in spite of Maxelf, if you have a seizures, then it is not eclampsia alone. There is something else which you are missing. Then you are going to give a anti-seizure medication. I agree with that. And as well, your Livera is a good drug, which most of the neurologists now give it to you. Levetiracetam, which is a safe drug for pregnancy and your lactation every period. So that they give you a 1 gram single dose as well. So can anyone tell me about IV antihypertensive dosage or oral nifedipines? What do you give in your setup?
See, IV and this labetalol, we can give like in each cycle, you can give like initially 20 milligram IV you can give and wait for the 20 minutes. If BP is not controlled, again you like the exponential dose, you can go for 20, 60, 80. And in a one cycle maximum, you can give it 300 milligram of IV labetalol.
Yes.
That is for the labetalol, yeah. Second, you can give a nifedipine, which can be given like 120 milligram in 24 hours. And then you can give otherwise you can give a hydrogen IV. So you give a 5 milligram of bolus dose, then we give the maintenance dose. That you can give. But mostly labetalol, it is available in most of the hospitals and for the IV doses. So that is, I think, the first line of drug for the hypertensive crisis.
So any of my panelists differs, they say they are going to use something else rather than IV labetalol.
No, so first line is IV labetalol alone. Yeah.
Yes, so IV labetalol is available uniformly. We have to know the regimen and we have to know how to go on in escalation. And all these nitropyrrozide and other things, I don't think any of the OGtion is going to go there. And once it is beyond our limit, then we involve the multidisciplinary team. You hand it over to your anesthetist or your intensivist in that point of time. So generally, what are all the complications that can happen with this hypertensive disorders and pregnancy? After
maternal
delivered or maternal, fetal. Yes, ma'am. Yes.
Yeah, maternal complications generally, as already we have told, there can be eclampsia, and she has already delivered. During delivery, she could have had an abruption, or if there was a fluid overload, she could go for a pulmonary edema or AKI, acute kidney injury, and also intracranial hemorrhage. In this particular patient who was mentioned 200 by 100, she could also go for a hypertensive
hemorrhage
bleed. So
Mostly
that is the
reversible
reason for most
encephalopathy.
of the that is one of the reversible condition, stress. So in hypertensive hemorrhage, they can also have a high maternal mortality risk.
Yeah, even that visual disturbances, I remember one of our patient, it was 200 by 130 BP. She came in early labor and she had a blindness. And which one almost it took 6 months to 1 year to resolve that blindness. So
Why
that can happen
for
when
so
BP was.
long? Because we have had cases which recovers quite early, madam.
Usually, 12 to 24 hours they recover the blindness.
No, that
if they
patient
have
took it
separation.
recovered, but the partial blindness was there almost for 6 months.
Okay,
So what happened that actually they didn't give her magnesium sulfate when the patient came. Like
Yes.
the person who was on duty, he told magnesium sulfate is a muscle relaxant, it will cause PPH. So that is what, So we should not, so anybody with a pre-eclampsia, eclampsia, magnesium sulfate should be given at the first, even if urine output is there or not, whatever.
Patient is coming with 200 and 110.
Yeah.
You have given her a Lavi bed, but still your BP is not controlled. And you've already started on max self. So anybody wants to comment on max self and this nifedipine together?
There were studies, ma'am, that
Previously,
cause hypertension.
Hmm?
the anesthetist is not happy when we give Maxelf and nifedipine when we are taking up for surgery. But we have had instances where we have given both magnesium and nifedipine. But what we are worried is about postpartum hemorrhage when we give both together, because they may relax the uterine muscle.
But most
They
of the
can
time,
cause
what
more
they
hypotension and neuromuscular blockade when we give together nifedipine and magnesium sulfate. There was a controversy, but now the guidelines are supporting nifedipine with magnesium sulfate, ma'am.
that is what I wanted
But we
to
have to monitor the blood respiratory status and
if
maternal
there
symptoms.
can be a fall in BP, we agree to that, but it should not stop us from giving both together. That is first point. Second point, there may be a PPH, but it is not very documented saying that if you give it together, compulsorily PPH and contradiction, it's not like that. You can give them together, and this neuromuscular blockade is not being told now. Initially, like during our PG days, they said you should never give at all. It will cause a massive neuromuscular blockage, but that time itself they said no, that is not the right thing. You can give them together. So it's always been a controversy, but as of now you can give them. Nothing major happens. So usually the most common reason for acute kidney injury in pregnancy, anybody wants to tell that? Most common cause of acute renal injury in pregnancy is
glomerular endothelial.
Pre-eclampsia, eclampsia.
Exactly. The most common cause of acute renal injury, or your this one acute kidney injury or AKI, is preeclampsia. So always watch for how the kidney works for this patient rather than landing up with a chronic renal disease. So there are people, like we had a discussion with the Kidney Warrior Foundation. There were people of renal failure and renal transplant patients, and most of the patients, they came back to us and told that when I delivered, I had preeclampsia. They saved me. They gave antihypertensive. We delivered, and after the baby delivery, I did not bother to check my BP. I was only taking care of the baby. I was only into that, and finally landed up with the nephrologist with a renal failure, and now I'm a CKD patient. So this is what happens to these women if we don't monitor them postpartum. So those are the things which we should remember. Recurrence is one point. Anyone wants to comment on recurrences specifically? What will be the percentage? If something is there, it is more like that. Anything?
Early onset preeclampsia, the recurrence for having a preeclampsia in the next pregnancy is more.
Yes.
If there is a GHTN in the previous pregnancy, the risk of having another preeclampsia may be little lesser, but GHTN is still there.
Yes.
So late onset preeclampsia, the risk of having recurrence is little lesser than the early onset
ones. Yes. And the more severe, if it is like, for example, at a HELP syndrome, 22-weeker, 30-weeker you delivered, then they definitely have a recurrence in the next pregnancy. So the next, yes.
Ma'am, what is your take on IV labetalol versus oral immediate release nifedipine?
See, usually, if you treat it as a OP patient, okay, we try to give nifedipine as the first strong because it is there, like in your clinic. Okay,
Immediately.
rather than nifedipine. Yes, the oral nifedipine is what. Usually we don't have the immediate acting or the sublingual ones which we initially used to give, because those have been documented to give like, a myocardial infarction and other things. So we don't have immediate relief nifedipine at all. Okay, so we don't have these sublingual nifedipines which we initially used to have those things. So those are not there, and these oral doesn't got like immediate relief, I don't say, but you can give them. They really work very well. So not every high BP patients needs IV labetalol. That is what we have found. Most of the time they work very well with nifedipine. But if you have a severe hypertension, sometimes like recently I had a patient 220 by 120, in spite of all the antihypertensive, it was not coming down. So we were all panicking. We were like, it was a twin and other things. So we want to stabilize the patient, and like, all the LFTs were high and other things, in spite, and everything happened after delivery. 24 hours after delivery, the BP shooted up. So we didn't have an option. We have taken out the placenta, taken out everything, but still, the BP went up. It was a panic situation, but most of the time they settle down. It takes time. You just have to give them supportive management, ICU care. They settle down, and then you can bring them back. So don't worry about that. Always, it doesn't mean that always it happens in the antenatal period. It can happen in the postnatal period also. And severe hypertension, how long you want to keep the patient inside your hospital? Discharge, 2 days, 3 days, 4 days, when you want to discharge. Severe hypertension, you have delivered her, LSCS. Now BP is come under control.
No, if it
in
is
the government
LSC,
sector, we keep at least 7 to 8 days.
7 days, yes, ma'am.
Usually we want to see.
So Dr.
Ma'am,
Meena wants to keep in 7 days. Okay, Dr.
10
Rahul.
Ma'am, we give thromboprophylaxis for such cases, so we keep them for 10 days, and
10
then
days,
again
Dr. Rahul.
we get a physician clearance. They will anyway say keep for 4 more days, so 2 weeks, madam.
2 weeks. So Meena,
minimum,
1 week,
yeah.
Dr. Rahul, 2 weeks. Others.
So minimum we should
7
keep the
days.
patient for
7
minimum 3
days.
days. Minimum 3 days. So we can call back the patient. Suppose patient is staying nearby, that hospital facility is there. You can call back the patient after 1 week. So, but minimum 3 days, patient should be there in the hospital.
Okay. So
before that, you
anybody
should not discharge the patient.
yes, so Dr.
I
Mara,
go with
Proper
Rahul.
dosing of antihypertensives. We can
In
discharge.
severe hypertension, we keep the women for 2 weeks. Mild cases, we keep at least for a week.
Okay, Dr. Majibin, yes, you were telling something. Sorry.
Yes, ma'am. With the proper dosing of antihypertensives, we can discharge the patient by 7 days.
Okay, 7 days. Dr. Pavitra and Abhinaya.
And they have to do home BP monitoring. They have to come back for the follow-up.
Yes.
Minimum for 7 days, ma'am. Definitely minimum for 7.
Pavitra also 7 days?
Yes, ma'am.
So actually, like, I think me and Sunita are the poor people where there is one more doctor. Sorry, I did not ask you. So how many days you want?
Most of the patient, even the private sector, they won't agree for 7 days.
Yes.
So minimum
The
we
insurance
can keep for
doesn't
3
pay
to
us,
4 days,
okay?
and then if the BP is
Patient
under
doesn't want to
control,
pay us.
if the BP is under control, then we can discharge her with the appropriate follow-up.
How many days?
3 to 4 days at least, ma'am. So for the 3 to 4 days, the BP
Actually,
should be
like,
under
though
control.
most of us will not agree with that. Most of the guidelines ask the patients to be staying with 3 to 7 days. At least 7 days is what is given in most of your recommendations. But however, in practice, if you have a very compliant patient who stays nearby, that she's going to have a bone BP monitoring. She's going to report immediately, after a high BP value. And now with the antihypertensive, it is under control. We all send home a little early. Very sorry, because our patients don't want to stay in the hospital and pay for us.
Yeah,
And
yeah.
like as last time also.
Yeah, I agree.
Our patients
In
also
the
won't want to
corporate,
stay, madam. We will use all sorts of threats to make them stay.
Our patients will go out
We
putting
have
one
to,
review
we
on
have to
that.
get the
Most of them
consent
go,
every day.
madam. Madam, here also they will abscond.
Yeah,
We will then inform and escalate it to the district collector, send a team, capture them from their home, forcibly bring them and admit them back in the ICU.
That's so
yes,
sweet.
yes.
No, you can
Actually,
do.
one thing is that in the corporate, we do have patients where we do have a good home monitoring and they are compliant with the treatment. We
Yes.
do discharge them at day 3. But
Yes.
as
Yeah.
Rahul said, we have a group where we follow up the women with the mentor OG team and the VHN. They go home, they take the BP, they counsel the women and get them back and at least admit them in the urban PHC nearby and give a follow-up to the
I
team
agree
which
with
has
that, Dr.
delivered.
Yeah,
Yes.
madam.
But
Because
you
we
know,
do have women who are readmitted with complications like severe hemorrhage or a press or severe
yes.
atypical eclampsia where the women has had eclampsia in the house. Again, we find out some other cause. We have had so many complications with hypertensive disorders who have just gone home, absconded from the ward.
Yes.
Ma'am,
I
As
even
Meena
yes, Dr.
told,
Rahul.
Dr.
Yes.
Right.
Wait. Yes.
If the patient is having a nearby facility, patient is well educated, she's well aware, then only we can discharge the patient after
Got
3
it.
days.
Got
That
the
is true.
both
Yeah.
points taken, Dr. Sunita. Yes.
Yeah.
Dr. Rahul,
Yeah.
you were telling something.
no, madam. Social obstetrics is a totally different issue, but as per the guidelines, minimum 7 days is recommended.
I agree with it, but actually, as Dr. Meena has said, even we have sent our patients home and who has forgotten to take their BP tablets, and then they come back to our own hospital, our own emergency, landing up with pulmonary edema, landing up with press, landing up with preeclampsia. We have had patients. It's not like everything. Okay, come on, corporate educated patients. They are well. They will do it. They are obedient. No, we get back with complications as well. So recommended period is 7 days, but sometimes you tend to budge to what they say, and it is a guarded decision which what we take, but it's always to keep yourself safe. Document clearly that they have to monitor the BP, report immediately after all these symptoms, and it should be at request discharge. If possible, keep them for 7 days. So that is the take home there. And this patient and upper abdominal pain, she has been on labetalol since 20 week. At 34 week, now she is complaining of pain abdominal. Is it help?
What about BP, ma'am?
Any upper abdominal pain, even without BP, we have to think about HELP syndrome.
So it is 140/90. So 140/90 rules out.
Even with the normal BP,
No, even with the upper
women can
abdomen,
have a HELP syndrome.
Why do you think HELP syndrome can cause upper abdomen pain?
The liver is the damage.
Capsular stretch,
Capsule
ma'am.
is a stretch.
Yes, so
Stretch
either
of
because
liver.
of your liver edema or your liver hemorrhage, it stretches the
Causing the
capsule.
stretching on the capsule.
Stretching of the capsule, liver capsule.
Okay. So fine. Now I am telling you, your bloods you have done. The patient is having a platelet of around 80,000 and her LFT is around 70, AST is 70, ALT is around 90. So what do you want to do? When you want to deliver her?
Right now.
Right now, I love that. So
Steroid and
Do all the
It's already
investigation to
34
look.
weeks.
yes, fine. So we have sent the
Actually,
blood.
look for.
Steroid and deliver.
Yeah.
Okay. So steroid means waiting for 48 hours.
No, ma'am.
No.
And one dose
We can-
of steroid within 3 hours we can deliver.
Yes. So you give the steroid, you send the bloods, because in bloods, what are the things which you want really to know? One is your platelet, because that will
Liver function test.
Hemolysis,
Yes.
the blood picture, the peripheral smear,
Yes.
hemolysis.
Yes.
Already you have told
Also
about the
sometimes
liver
it will
enzymes
go in
which is
for
elevated
DIC as
and
well. Your health syndrome,
yes.
most of the time they come with PT, APTT prolonged as well. Okay, so is there anyone saying that, okay, I will give platelet, I will give cryos, I will give FFP, stabilize the patient, then deliver? So what is your take on that?
No.
PT,
No.
APTT is little
There
prolonged.
should be
Not little.
immediate termination. No.
No, ma'am.
Why no? Or APTT, or INR is 2. What do you want to do?
Immediate delivery only is
Why
Budget
is all
expenses.
your panelists saying delivery?
With the
Because
right
the culprit is
Termination is the
inside.
treatment because
Placenta.
basic pathophysiology is the placenta. Once the placenta
Yeah.
is removed, most of the things, the physiology
Will
tries to
reverse.
come back. The pathology tries to reverse.
Anything else you want to add? A PT, APTT, or INR is 2. Anything you want to add?
FFP before delivery.
We should keep the blood
Usually,
product ready. Patient might have the bleeding.
Dr. Sunita, yes, go ahead.
Yeah. We should keep the blood product ready. FFP and the platelet should be ready. But
Yes.
our main aim is to deliver because the culprit is still inside.
So once the
Exactly.
delivery
This is
happens,
the word I
yeah,
want. Get the
yeah,
culprit out, then only you'll be able to stabilize the patient.
yeah.
There is no point in correcting the INR and then planning delivery, because you will never be able to correct the INR
Correct.
till the placenta
INR with
The placenta is inside.
Okay, so the placenta outside, but be ready to correct the INR as well. Okay, because that Q card is that INR is there. So for delivery, for help, it is like, initial stabilization means the BP control, giving of a certain dose of steroid, sending some bloods, and all those things are the initial situation, not like completely normalizing or PTA, PTT, completely stabilizing will never happen. Okay. And is there a role for vitamin K injections in these patients? Vitamin K. No.
Generally we don't give.
Yes, why? What is the role? What is the relationship between vitamin K and these kind of scenarios? Because one doctor asked me this question.
Vitamin K is for those factors which are requiring vitamin K. Here,
Yes.
the basic pathology is entirely different. The coagulation is not dependent on the vitamin K. So, once the placenta is removed, whole pathophysiology tries to revert back to the normal. It takes some more time.
Yes. Here, there is a problem with the liver. Your liver is not giving you factors. Okay, so there's no point in just giving you the vitamin K. Even if you give the vitamin K, your liver is not going to give you further factors there. So till you take out the injury, your inflammation comes down, your liver starts recovering and starts working on its own.
This
So
mainly because of the consumptive coagulopathy, not the vitamin K deficiency.
Yes.
Giving vitamin K.
No, that is for a whole full-blown DIC kind of thing, which is consumptive coagulopathy. We are not talking about a full DIC situation here. Most of the time here it is because of some clotting problem and it recovers. Okay, if you wait the help, I agree with it. If you give them 24 hours or if you give them more than that, then you go ahead and have problems. So I think the mode of delivery. So how do you want to deliver? Taka, 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 we'll just finish it off fast. So a patient 23 to 32 weeks, how do you deliver?
24 to 33 weeks, I think we should go for a cesarean section.
Okay.
Because it is a very
If the
preterm.
patient is stable, the modified Bishop score is good. We can deliver vaginally with a good ICU setup, multidisciplinary monitoring, because always the morbidity with the vaginal delivery is better. But if it is a severe
Sorry, Dr.
preeclampsia with all the...
I'm interrupting there. Do you think a patient will have a good Bishop score at 32 weeks?
33 weeks. Yeah, and that too, it will take some time because when we are seeing a severe preeclampsia or eclampsia, 24 to 33 weeks, as such, Bishop won't be good. And we cannot take a more than 24 hours for the delivery also. So once you are
Okay,
inducing
Dr.
the
Rahul, you
patient,
wanted to add something. So what
If
do
it
you
is a
want to
previous normal delivery, most of the time, sometimes the Bishop score may be good. So it is important to assess instead of giving a generalized statement to deliver
I
abdominal
agree
approach.
with my panelists, both my panelists. So you will individualize your case. You will assess the Bishop score. If you feel, because most of the time what we see in practice is that these preeclampsia cases, they respond very well to your inducing agents and they deliver early. For example, a patient without preeclampsia and with the preeclampsia, they have a shortened labor when they have these kind of things. So they usually progress favorably well if the Bishop score initial is better. So you individualize your case, but not for a 2 preterm babies. Less than 30 weeker, 32 weeker, I don't think we will be giving that. But after
they
32
can,
weeks,
what Priya told, they can deliver vaginally. But if you see the baby outcome, extreme preterm is always better to go for a cesarean section for the baby's sake.
Yes, and depends upon the NICU setup and how much your NICU can save that.
Yes.
And it also depends upon how much of FGR, what is the weight, what is the Doppler changes.
All those things you have to take care.
Yes, so you individualize the treatment. And any comment on fluid management in these patients? Imagine your patient has done cesarean, has undergone cesarean. Any advice you will tell your juniors about the fluid management? Dr. Sunita.
Yeah, fluid has to be restricted. It should be 75 ml per hour like that you can give, because in these conditions it is a hemoconcentration. So once you give more of fluid, so there will be chance of pulmonary edema. So always if fluid, it has to be restricted, maybe 75 ml per hour. Particularly when you give.
Okay, anyone wants to add anything?
The same. Fluid restriction,
So
mainly 75 ml per hour.
Yeah, so that is then any Okay, and Dr. Rahul, you told about thromboprophylaxis. So what do you want to give? How many days you want to give? And do you give it for all preeclampsia patients?
Yes, madam. As per the NHM's protocol at public hospitals, we give for all preeclamptic patients. We give enoxaparin 40 milligram once a day for 10 days.
10 days.
Or more
Based on
if
the
there are
weight,
any
basically,
additional comorbidities.
based on the weight, we give the low molecular weight heparin. Some of the women may be having a BMI of 47.8. So individualize the heparin what we are giving based on the weight.
Okay.
We
And
give it for 7 to 10 days.
Okay. Do you give it for gestational hypertension as well?
No.
We
No,
give,
no,
madam.
no, ma'am.
No.
At our center, we give because we have received instructions from the public sector hospitals to give that way.
Okay, so it
We
depends
give for
upon the
this hypertension
individualized
also.
protocol. Anybody has used the oral anti-10 inhibitors?
No.
No,
No.
ma'am.
Yes, because actually, no, if you give it to the physicians, they give you the oral ones. But according to our guidelines, it is not safe in lactation. So we are not supposed to give. So now I think, like this patient who delivered 2 weeks back, she is a gestational hypertension. She had antihypertensive therapy. Now she is having headache, BP of 160 by 100. And this is the MRI image. Diagnosis?
It can be press.
Press, posterior
Press.
reversible encephalopathy syndrome.
It is press because this is typical features of press. Okay, this occipital lobe edema, very typical features which we put it. So how do you manage press?
Treating with the antihypertensives to reduce the BP. That is the mainstay of treatment.
Okay.
So if there is no there is a headache, so we need to give anti-seizure medication. Magnesium sulfate should be given and followed up the patient with a multidisciplinary team approach, not only giving antihypertensives and seizure control. We need to do a MRI or a MRA MRV to see for the other changes as well after getting a neuro opinion, because in this picture it is already given. When she comes to us without investigation, we evaluate her with the neuroimaging.
Any patient delivered coming with the headache, you have to have a neuroimaging. There is no doubt at all. So here it is a press. So what is the basic concept about antihypertensive therapy in press is that there should be no peaks and troughs. That is the concept there. So what happens is that the patient skips the antihypertensive. Then when they measure 160, 110, they give a nifedipine, suddenly drop to 90, 60. Then they skip the albuterol. Then it goes up. So when you get these up and down values, these patients land up with press. So a stable control that should be there for this patient. So, and anybody doing this SFLT by PLGF ratio, especially to predict the preeclampsia, in the later gestation, they say when you have that, it predicts the severity of preeclampsia within a week's time. So anybody doing that?
So this is only we don't do, but mostly for the research purpose.
Yes.
I have done for this MMF and SFLT1 for this preeclampsia prediction. But practically in most of the, because it is very costly, we cannot do for each and every patient.
True, I agree with that. So I'm not going to go there. So before ending, I just want every one of my panelists to give one take-home point for the for the audience. Dr. Meena? Yes, Dr. Rahul, yes.
Yeah.
I would start with the prenatal counseling to optimize the general health of the patient for weight reduction, or if she's diabetic, to kind of get her sugars under control. So to rationalize the use of ART and all. So if we do that, we can prevent a significant chunk of hypertensive disorders in pregnancy. So my take is I would start on prenatal counseling.
Yeah.
Excellent.
So second, I will tell in the early trimester, one is prenatal counseling. Then in the early trimester, you should start with the gestacy score. We should prevent it. That means in the first trimester itself, we should see the risk factor. We should do the first trimester when you are doing the scan and the NT scan. That time you can take the uterine artery PI and the PAP score, PAP level, PAP-A level, all those things, so that you can start with the ecosprin and we can prevent. So it is very important is the early pregnancy, calculate your gestacy score and accordingly you can treat the patient.
Predict and prevent, you have told. Yes,
Yeah.
Doctor. I agree.
Ma'am, as you had said earlier, we should look for a baseline BP. Even if there's a rise in 20 to 30 milligram, we have to monitor closely. That is also very important.
So post-natally, the adequate emphasis has to be given on hydration to the patients, because they doesn't know, even when most of the patient end up in C-section because of the preterm and iatrogenic everything, and because they don't know the importance of the hydration, and because it was a C-section, they don't mobilize also. So adequate emphasis
The
has to
risk
be
of DVT becomes very high. I agree with it, Pavitra. Yes, yes, Dr. Meena.
Yeah, as you already mentioned, think of eclampsia unless proved otherwise. Think of complications whenever we are treating a case of hypertensive disorder of pregnancy. Always have a suspicion in the mind of thinking of maternal complications rather than the fetus. So mother comes first, then comes the baby, and also always individualize the care. It is not like do cesarean for everyone, do normal delivery for everyone. Give the time limit between 6 to 12 hours she has to deliver. If she doesn't deliver, have a low degree of threshold for having a cesarean section done, and always alert the entire team, the multidisciplinary team, the ICU team, the anesthetist, the hematologist, the physician, the neurophysician. Everyone should be alerted if a woman with preeclampsia is admitted. Always make them think of some complications rather than thinking she'll go normal throughout. Anticipating complications and treating the women early will prevent her from having complications.
Okay, okay. Dr. Majubin, yes.
Sorry, ma'am, my phone got switched off.
Oh. Yeah,
I think
actually,
they
we
have
are
covered
on,
almost yeah, they have
yes.
covered almost everything. So
Yes,
preeclampsia is just a disease. It's a disease of placenta, but the maternal syndrome, it is results from the widespread endothelial dysfunction. We have to treat as the mother should comes first. I mean, we have to treat the preeclampsia, and early prediction is very, very important. Starting antihypertensive therapy, which is very important, and follow up. We have to inform everything about preeclampsia to our patient. Get the consent, even in the OPD basis, we have to tell everything and get a consent regarding the complications. And we have to have a close monitoring of the patient.
A very important point, always document. Get your OPD files as well into a EMR or an electronic monitoring, or at least have a record saying that you have explained to the patient and it's the patient's choice to go home or deny your advice. So I think, any of the panelists, if I missed, I'm really sorry if anybody else is there. So, or otherwise, I think all of you are answered. So thank you very much. I really like to thank Dr. Sambat Kumari Madam for this wonderful opportunity, and thank you, Dr. Madhumita, for such a good organization and very well done webinar. Thank you.
Priya, just last one point.
Yes,
Priya,
ma'am.
yeah, yeah. So because many times I have seen just because of the preeclampsia, eclampsia, the right indication is a preeclampsia when you do LSCS. So preeclampsia or eclampsia per se is not an indication of cesarean section. Only for the obstetric indication we should do.
Yes.
That is another
Not for
important point.
every term babies.
Yes,
So
yes,
when
yes,
we
yes,
agreed for cesarean, we agreed for these pretermers who are less than 32
yeah.
weeks. We are
Correct,
not
correct.
talking about these term patients who will have very well chances of delivering vaginally.
Very correct. As you told, like
They
particularly
progress very
preeclampsia
fast.
patient, they
Don't
go
get-
for labor very fast
Yes.
once you induce them. So per se, preeclampsia, eclampsia is not an indication for a cesarean section.
Yes, and delivery,
Thank
we
you.
mean early delivery is within
Yeah,
24 hours. If
correct.
it's severe preeclampsia or even help, it is within 12 hours. So it is not like rush and immediately push them to the cesarean table. You can still, like individualize the patient's choices.
Yeah.
Yes, ma'am.
Thank you for the opportunity. Thank you.
Sambat, ma'am.
Thank you so much, Priya. It was a wonderful panel, and always having a good network with the private sector, public sector, and as well the patient, the VH, and the UPHC is very, very important. And also counseling the entire family is very important. Making sure the entire family knows, because they don't want to tell the mother-in-law, father-in-law what the woman is undergoing. So to reduce the maternal mortality to zero, we need to work as a team. And preeclampsia, eclampsia is one of the important complications to cause a maternal death as well. Thank you for the wonderful panel, Priya. We enjoyed it. On behalf of the panelists, we would like to thank you. And Sampath ma'am, Dr. Madhumita Arun Karthik, for having given us the wonderful opportunity as well. Thank you so much.
Yeah,
Thank you so much, madam.
Request everyone to vote for Sampath ma'am.
Best wishes to Dr. Sampath Kumari madam.
Yeah, and kindly voting is your right. So your Foxy elections for the presidential candidate comes between August 1 and 10. Voting is everybody's right. So kindly make use of it, and kindly make sure that you are a category A member. So just fill in the form, make sure you're already a category A member, and kindly vote and try, remembering us and Dr. Sambat madam. Thank you.
Thank you, Priya. Wonderful panel. Always panel moderated by Priya is great. Anyway, thanks to the panelists, Dr. Meena, Dr. Sunita, Dr. Pavitra, Dr. Sunanta, Dr. Abhinaya, Mahajabin, and our Aravind, Anand, Rahulan. Anyway, nice, Priya. It is always pleasant to hear you. Madhumita, are you there? No, she might not be there, I think. Anyway, thanks to all the Uttarakhand Society President and Secretaries and our own Priya Kannappan and the panelists for the wonderful panel. And thanks to Dr. Madhumita and Sahiti for good coordination. Thank you. Have a good day. Good night, all of you. Please vote for me. Voting is from August 1 to 10. Please make all your friends also to vote for me. Thank you. From down south, we should not miss the opportunity. Thank you, Priya.
Thank you.